So we begin the next session, and Dr. Alka Subramaniam is going to chair the session. Is there anyone in this house who doesn't know Alka Subramaniam? Is there anybody in this house who doesn't know Dr. Alka Subramaniam? Right, so here's Dr. Alka Subramaniam. It's a pleasure to introduce Dr. Subramaniam as just one time, that the first time that I met up with her. I was the examiner and she was the examinee. And at the end of the session, she taught me a thing or two. She stood first at that exam anyway, but that's Dr. Alka Subramaniam, modest, persuasive, very sure, and willing to part or share her knowledge. Dr. Alka.
Thank you so much, sir. It's very kind of you to always remember that. I'm not sure I'm worthy of that, but thank you. And thank you for always having me as part of the Dr. N.S. Vahia Foundation. We're very happy to have the McLean team along with us here, and this is just a startup to a whole series of talks arranged next week with the purpose of destigmatizing psychiatry, which is what their forte has been, and we have Scott and Adriana who have taken that ahead in case you hadn't heard that already. Our next speaker is someone who's a very young and dynamic person, and so I think very appropriate for the topic that she's going to be presenting on, which is innovations in child psychiatry. Don't get fooled by her youth. She's a medical director of the child psychiatry unit at McLean, and she handles both, I think, inpatient and outpatients over there, specializing in childhood anxiety disorders, OCD, and mood disorders. And recently she's doing some very exciting work with IPSIT on digitalization, including at a school level. So she actually penetrates not only in a clinical setting, but also the school, the child community, which is the school setting. And I'm sure she's going to have a lot of interesting insights to throw. So may I invite Ms. Dr. Mona Potter, please come. So I think you have about an hour.
Well, does this work? Okay. Okay. How do I go back?
Yeah.
Back this way? Okay. Okay. So I am officially on day 2 in India, and so I apologize in advance if I go blank for a moment due to jet lag, but I think I'm doing okay. I just had a little extra tea, so I think I'm okay. But I wanted to thank Dr. Vahia and the foundation for having me here. It's just been, even in the kind of 1.5 days I've been here, I've had some really wonderful conversations, and that have just really sparked all kinds of just interest and thought, and so I'm really, really excited to continue these conversations. So I've been asked to speak about some of the innovative approaches that we are taking in our clinic in Boston. I want to take special note that I recognize that the resources we have in Boston and the structure of our clinic is different from what is here in India. And so I'm not standing here saying what we're doing is what should absolutely be done here, but instead wanting to share a little bit of what we're doing and in turn also learn what's happening here and think about ways we can kind of transpose ideas and really come up with wonderful treatments for the patients that we treat. So I wanted to start, though, by saying I've visited India many times personally, but this is my first time to be here professionally, and it's really meaningful to me. So that's a picture of my great-grandfather, my dada, who was the first medical doctor in Sankera, so it's a district of Vadodara. And I still remember being 5 years old and visiting his clinic, and just seeing the compassionate care that he provided for the village of people, not only immediately around him, but to villages surrounding him. And going back to America and saying, I am going to be a doctor, just like my great-grandfather is a doctor. I want to make a difference. And so fast forward, I'm the medical director of child and adolescent outpatient services at McLean Hospital. And while my clinical setting is quite different from that of my great-grandfather, the mission is the same. And that's to provide compassionate care for our community and to really reach out to people. And so in our child outpatient clinic, we have 5 programs. And so we have a general outpatient clinic that provides therapy, medication, and kind of on an individual and group basis. We have neuropsychological testing. We have a new program that's called the McLean Anxiety Mastery Program that I'm going to be speaking a little bit more about, where we work with kids struggling with pretty severe anxiety disorders. We have a program that's centered on DBT for children and adolescents presenting with suicidality, self-injury, kind of very risk-taking behaviors, and kind of major safety and emotional issues. And then our newest program is our school consultation service, where we've really been trying to kind of expand our reach and work with the community and really take what we're doing in the clinic and expand it. And so I feel a very big privilege to get to work as a child and adolescent psychiatrist, in that the child and adolescent brain is in kind of prime time of development. So there's so much opportunity as it's developing, and there's also quite a bit of vulnerability. And so so we really think about these interventions as much as we can kind of get them early and make changes, we can build a really strong brain. And so the kids in my clinic, I went into psychiatry because I was just in love with the brain and kind of the intersection between brain and behavior. And so, we talk quite a bit about the brain in our clinic. And so the child brain, we think of, is very different from the adult brain, and it's quite relevant as we think about child mental health. So, we're still very much work in progress in understanding the brain. So please understand that anything I say about the brain, we might have completely different understandings in the years to come. But at present, kind of how we see it is that the child and adolescent brain is very much still developing. And it develops from a kind of back to front order, right? And so that frontal lobe, that higher order thinking part of the brain, is the last to come on. It's thought to be really matured by age 25. And instead, the limbic, or kind of emotional centers, are earlier to come on. And so you can think about adolescence where they're really feeling emotions strongly, which is actually good, because when you feel emotions, that adds that emotional salience to things. You're more likely to learn and to code things in your brain. And so that's a wonderful, helpful thing. It can also be a vulnerability. And so, and what we also know is that this maturation happens at different rates. So for example, there's been a study that showed that in children with ADHD, their brains, their frontal lobe matured on average about 3 years later than their peers. And so again, so not only kind of as a group, is there this developmental difference, but also kind of individually, and that can, again, as I'll speak in a moment more about, it can lead to great vulnerability. The other thing that I make sure to stress when I'm speaking with any adolescent who comes through my door is as their brain is developing, there's so much that they can do as they think about how they're making decisions. That their brain is shaped by their experiences. What they practice is what is going to start getting coded in their brain. So what we do know, again, about the teenage years is that it's a big time of what we call synaptic pruning, meaning, yeah. Thank you. Meaning that experiences that are practiced over and over are the ones that are going to get coded more strongly in the brain, and then myelination happens to help those signals happen faster. And so again, we used to have this statement that said practice makes perfect. We now say practice makes permanent. The more you practice something, the more it gets coded, the more it's going to be kind of your automatic response to something. And again, if you, so we'll come back to this too. And so as we think about this developing brain, we know that there's all of this opportunity to grow and to learn, but with it also comes that vulnerability. And so from epidemiologic studies, we know that about half of mental illness begins by age 14. So that's significant. That's really significant. And the disability can be huge. And so what we found in the US is that over 1/3 of students with a mental health condition drop out of school. And so this mental health these mental health disabilities actually really contribute to major disabilities. And so this is, it's a slightly old study, but it was well done in kind of looking at general lifetime prevalence of childhood psychiatric disorders. And as you can see, anxiety disorders are top of the chart, where by age 18, about almost 35% prevalence among children and adolescents. And what we're finding is that this is extending on to universities and colleges as well, where anxiety disorders have surpassed even depression for kind of reason for presenting for help and kind of challenges related to being able to attend college and get through their daily life. So I was curious what it looked like here in India. And so I found the National Mental Health Survey. And within the large survey, they looked at a subset of adolescents in 4 of the 12 districts that they surveyed for the entire survey. And similarly, we did find that anxiety is relatively prevalent among the children and among the adolescent population. And that being said, we know, again, India is a very diverse country where there's great difference between rural settings and urban settings. And so there was another study actually that showed, that looked at anxiety prevalence, specifically in English standard private school here in Mumbai. And I will say that I was actually quite taken by how prevalent anxiety disorders were in this study as well. And anxiety across multiple different kind of subclasses of anxiety. So the New York Times was one of our prominent papers in the United States, has been running multiple articles on anxiety. It's become kind of the topic of conversation wherever I go. Whenever I go to schools, people want to talk about anxiety. Because what's happening is that it used to be that it was kind of a forgotten disorder or not such a big deal. Oh, we all get nervous sometimes. What we're seeing now is that the degree of the severity of the anxiety is you cannot be ignored, and that it's presenting at earlier ages and causing more disability. Just in the recent kind of 5 to 7 years, we've had more children stop attending school due to anxiety. And what we're also finding is that it's kind of the gateway disorder in that if left untreated, it leads to secondary problems like substance abuse or depression or kind of impaired quality of life. And so it's something that while historically was kind of looked at as not such a severe disorder, relatively speaking, it has started gaining much more kind of importance in need of intervention and need of intervention earlier in the game. And what was also really striking is that when we look at treatment, and I'm a little, I'm nervous saying this even here, where we talk about in our clinic how we feel kind of resource limited and how we wish we had more resources. And then I come to India and I realize, okay, I have no right to say that. But even with the resources we have, we notice that there's a big treatment gap in that up to 80% of children and adolescents with anxiety disorders are not getting treatment. And that's for a lot of different reasons. And some of it is stigma, some of it is access to care from a financial perspective, some of it is also the supply, that the demand for care has exceeded even the supply that we have. And being in Boston, we actually have a pretty reasonable supply. And so what that's led us to have to think about is how do we expand our supply without expanding our workforce? So what are more creative ways in which we can address this problem? So again, innovations in child psychiatry, I'm focusing in more specifically on anxiety disorders kind of for this portion of our time together. I'm just going to go through some of the basics of the etiology, then talk through the best practice treatment, and then what I will do is go through some of the non-pharmacologic treatment approaches that we're doing in our clinic. So what we know is that the bottom line is that both biology and genetics impact the kind of the presentation of anxiety. And so it's estimated that genes contribute to 30 to 50% of the development of anxiety disorder. So we see that there's familial passage of anxiety, and we're better understanding the biology that leaves somebody very vulnerable for anxiety disorders. I'll talk about the brain piece in a moment. But we're also learning how environmental issues can really impact it as well. Anywhere from kind of a big traumatic event that can cause epigenetic changes to daily stressors that can cause not only kind of epigenetic changes, but also kind of psychological changes that, that again, code in the brain and lead somebody to more vulnerability. Again, leading to lots of opportunity for intervention. And so it used to be that we thought about the brain, the anxious brain being kind of singled out to the amygdala. Kind of one part of the brain causes fear, and that's kind of the abnormality. And what we're learning as we're becoming more sophisticated in our ability to for neuroimaging is that it's actually a network, and it's actually the connections between multiple parts of the brain that really matter. Both in rodent models and in human models, we're really better understanding it. And again, as I talk through the next slides, big caveat that this is still very much a work in progress. We're still very much understanding it better. But what I found is that providing this psychoeducation, even at the stage where it is helpful for families and children to kind of say, all right, so there's something happening here. And then we bring in and your brain as an adolescent is very malleable. And so even though you have these vulnerabilities, you have opportunity to address these vulnerabilities. So let's get to work. And so a couple of things that are notable about the pediatric anxious brain. One is that the amygdala, which has been charged with initiation of fear response, it's been shown to be overactivated in fMRI studies with fear-based anxiety disorders. And so when a child with anxiety is put in an fMRI and compared to a child without anxiety, especially that right amygdala lights up in response to kind of fear faces. So it's more sensitive to threatening or fearful stimuli. What we're also learning more about is an attention bias to threat. And again, very much still a work in progress to better understand this, but there's been some evidence to show that abnormal functioning in kind of that prefrontal cortex, specifically in that ventrolateral region, has been associated with an attention bias to threat. And this can be either by kind of facilitating attention to the threat and just kind of focusing in on threat compared to everything else around. It can be a hard time taking that attention away from the threat. So again, not only are you focused in, but you can't actually shift your attention to something less threatening. Or it can actually be more of an avoidance of the threat altogether. Again, unfortunately though, none of these are productive in managing the threat that's in front of you or kind of properly being able to get through it. And so again, the amygdala kind of detects and determines the level of threat, while the ventrolateral prefrontal cortex adjusts our attention to help determine how our response is going to happen. And so, as I said before, it's not just about these individual brain regions, though. It's about how they connect and how they interact with each other. And so what we're also finding is that that amygdala that's at the center kind of the fear response is communicating with all these different parts of the brain. And these communications are, again, in a normal state, going to help us kind of make sense of what the amygdala is kind of responding to from the environment. But what we're finding is that in the brains of anxious individuals, that connection is altered. It's altered in multiple different parts of the brain. Anywhere from the prefrontal lobe that's about attention and kind of making sense of it, to kind of the insula, which is more about kind of our physical response. So we notice that a lot of times when somebody feels anxious, they'll feel it in their body, and they're very much more sensitive to feeling those feelings in their body. They're more worried when their heart is racing or when they're sweating, and so how they make sense of that. And then the cerebellum is a relatively newer player in this, but there's some theory about how it impacts the amygdala cerebellum interaction impairs kind of how we learn that fearful events are in fact not as dangerous as we think. All right, so I'm going to go through now the best practice treatments, that kind of what we use kind of a standard of care in our clinics in the US. And so there are a couple of seminal studies that we really go to. They were well done by the National Institute of Mental Health, kind of longitudinal randomized control trials. One is the CAMS for pediatric anxiety, and the other is the POTS for pediatric OCD. And so in the CAMS, they had 488 children and adolescents aged 7 to 17 participate in CBT, or cognitive behavioral therapy, for 14 sessions. And so one group had CBT alone, another group had sertraline alone, so max dose of 200 milligrams, average dose of about 140 milligrams, and then CBT plus sertraline, and compared to placebo. And what they found was the CBT plus sertraline group was significantly, had a significantly higher remission rate than any of the other groups. And then similarly in pediatric OCD, in the POT study, where they had, it was a 12-week study of CBT plus exposure and response prevention, or ERP therapy. Similarly, they found that the combination group was superior, although they also found that the CBT was superior to medication and placebo. And so, this might be a repeat for most of you, but I'm just to kind of set the stage, just going to kind of go through very quickly the fundamentals of CBT. Again, saying that CBT is kind of the right kind of current best practice for pediatric anxiety disorders in our clinics in the US. And so traditional CBT is weekly or every other week. Individual sessions last about 45 to 50 minutes. And one of the really big components of CBT is actually psychoeducation. So I talked through some of the brain findings that we'll talk about. We'll talk about kind of anxiety disorders, and you include the parent and the child. And at the heart of CBT is the three-component model. The fact that you have thoughts, the feelings, and behaviors, and they are all connected. And so CBT works well in that it's goal-directed. So patient and family come in and they say, we have a set goal that we want to work toward, and we're going to work, and then you work towards that goal. And so as part of the three-component model, you're going to kind of target all three of those. You're going to target the thoughts, you're going to target the feelings, and the behaviors. And so through thoughts, you're going to target cognitive restructuring through, for example, catch, check, change. So we call it detective thinking. So you'll catch an automatic negative thought, you'll check it to check the evidence for and the evidence against it. And then if you find that it's not accurate, or if you find that it's causing distress or causing you to not engage in something that's important to you, then you're going to try to change that thought to something that's more productive. From the feelings component, there's the component of how you feel your emotions and kind of being more aware and labeling emotions, labeling angry, labeling sad, labeling anxious, but then also labeling the intensity of those feelings. And then there's also the physical feeling, and kind of where in your body do you feel anxiety? Many kids, especially the younger kids, will present first with headaches or stomach aches, and so oftentimes the first time they come in, we'll hear that they've gone to the school nurse multiple times, and it's really, they're not saying I'm feeling anxious or I'm feeling scared, they're saying my stomach hurts. And that's really kind of how they're communicating. And so kind of helping them just recognize where in their body they feel the anxiety, and providing them with some techniques to be able to kind of soothe the physiological symptoms of anxiety. And then the final component is the behaviors, right? Where kind of having people experience kind of do exposures to the fear. Because what can happen is that you might have a thought of, let's say I'm nervous that if I want to play cricket, but I'm nervous that if I go, that I'm going to miss the ball and everybody's going to think that I'm a failure. And so then you're going to feel sad and you're going to feel anxious about going there. And then your behavior is going to be, well, maybe I just shouldn't go. The problem then is that you never got to experience whether or not that really was going to happen. And so what we encourage the children to do is actually engage in whatever behavior is fearful to them, to actually be able to see truthfully what's going to happen and challenge some of those fearful thoughts that happen. And so once they complete this, we go through skills, they are given homework. where they go home and they actually practice the skills. And so again, the idea is changing the way that they're interacting with the anxiety. And then we use reinforcement and rewards. And then towards the end, you kind of talk through, okay, what has worked in your therapy? How are you going to kind of continue this? And when your anxiety comes up, what will you do to manage it? And so what some studies have shown that have kind of looked to the components of CBT that are most effective, they've shown that the homework component and the behavioral experiments are probably the two most active ingredients of CBT, saying that when somebody is constantly practicing it and integrating it, again, it makes sense. Their brain is more likely to code it. Those synapses are going to be the ones that are getting to stay online. Myelination is happening, and so the processing is quicker. And what we also know is that you can talk, but for children especially, they learn by doing. And so it kind of makes sense that two of the pieces that are really helpful and important are the homework and the behavioral experiment components. So back when I was talking about the CAM study and the POD study, great results that almost 80% of kids with anxiety reach remission, and kind of around 60% with OCD. But that still leaves 20 to 50% of patients who do not respond to these treatments. That's still a lot of children. And these are research conditions where we know that they're well controlled, and kids are coming on a regular basis, and there are many exclusionary factors, and so these kids have kind of pretty straightforward anxiety or OCD. And so, but when we kind of think about clinical practice, like when I think about the practice we have at McLean, the kids haven't seemed to have read those research protocols, and they come in much more complicated states, partially because they've been suffering silently for so long. So by the time they come in for treatment, that anxiety has kind of escalated, and they've developed some secondary comorbidities like depression, or they have ADHD that goes along with it, or learning disabilities, and so that complicates the picture. And by the time they get to us, they've kind of learned that if I'm afraid of something, if something makes me feel uncomfortable, I'm just not going to do it, and then I feel better. And so avoidance has become something that they really started using as their response. And as a result, they've started losing out on things that are important for them in their lives, whether it's school or social engagement or kind of extracurricular activity. And what we've also found is that by the time all these complications happen, treatment is a lot harder. And so many of them will come in not having responded to the treatment in the way that we would have hoped. I'll give a little example just to kind of break it up a little bit. And so I changed her name and some details just to kind of keep some confidentiality, even though we're kind of across the ocean right now. But we had Molly come into us in our anxiety program. And she's a 16-year-old 10th grader who, she's in a very, very competitive high school, which is kind of nationally known. And she was a straight A student. So it's a very impressive thing to be a straight A student in this school. And star soccer player, very close and loving family, and very eager eager to please and do the right thing. So she was kind of moving on along, seeming to do completely great on the outside, then went to summer camp, then all of a sudden went to the counselor at summer camp and said, I want to die. And so she was sent home immediately to the care of her family. And it was then that kind of everything started coming out, that for a long time she had been, despite functioning so highly internally, been really struggling with multiple different anxieties. So OCD, social anxiety, depression, generalized anxiety, and perfectionism. When she came to us, her eye contact was completely downcast. She had a baseball hat on, barely engaged with us, and barely spoke, and was completely disengaged. Her coping strategy was to basically shut down and avoid everything. She had stopped going to school, stopped interacting with anybody and everybody, stopped playing her soccer, and she was completely isolated, to the point that we were wondering, is this psychosis? Is she having some kind of a psychotic break? Is this prodromal or even kind of on its way to full on? But when we looked at her from a cognitive perspective, there was no decline in cognition. And as we got to know her, when she's trusted, we saw that she was actually quite relationship-oriented and actually could engage quite a bit. And so it was a great example of how severe anxiety can really mask itself in other ways. And so So she came with us for treatment in our anxiety program. And we started, as we do with most kids, with CBT and exposure therapy. And that actually did pretty well to address her social anxiety and some of her OCD symptoms. However, as she was going through treatment, her suicidality returned, and actually urges to self-harm started going up whenever we asked her to challenge her perfectionistic thoughts. So we'd say, okay, maybe, maybe you don't need to be perfect. Maybe you don't need to take all of the hardest classes. Why don't you think about dropping one of those hard classes and challenge the thought that if I don't get 100%, I'm not going to go to college and then my life is going to be a failure. It was very difficult for her to challenge those thoughts. So I'll come back to her in a bit and to kind of continue to walk through what we did with her. But what this does illustrate is that with still a group of people who do not respond to the treatments, what we're realizing is that we do need to get innovative in how we're helping these patients. Not only because the treatments that we have their limitations, but also they're pretty onerous, and we're not meeting the needs of enough kids. And so the treatment gap plus kind of the efficacy lead us to in our clinic start thinking about what else can we do and what else can we integrate. And so I'm going to talk through some kind of broad categories of innovation that we have started doing in our clinic. And again, this is kind of a launching pad for discussion, recognizing that we're a unique clinic and that not a lot of what we do won't translate beautifully to kind of a setting here in India. And that being said, I think there could be some opportunities for collaboration. And so one thing that we've thought about are some structural considerations. And so we talked about how traditional CBT has been delivered on a weekly basis, kind of in that 45 to 50-minute individual treatment. And so kind of more recently, there's been attention to thinking about what if we were to give the treatment on a more intense basis? And so instead of having kind of these 14 to 16 sessions spread over the course of kind of months, what if we were to give these sessions kind of in the course of days or a couple of weeks? And so there's a meta-analysis that looked at 23 randomized controlled trials, looking at treatments that were delivered kind of on a briefer basis, so kind of ranging from kind of 4 days of intense CBT and exposure therapy to kind of a couple of weeks of it. And they found that intense treatment was at least as effective as kind of the longer-term traditional CBT, with two primary components being the most helpful part, the cognitive restructuring component and the exposure therapy component. And so what we've found in our clinic, so in our anxiety program, we have taken this, and so we provide kind of intensive treatment over the course of 4 weeks. And what we've found is the benefit of engagement, in that when you're with somebody every day, they're more willing to come back, and they're more willing to do the homework that you give them because there's accountability that's built in. There's the opportunity for people to kind of take that time to come to you and kind of really throw themselves in treatment. And so we have lots of people local, but we have people kind of relocate from elsewhere where they don't have resources to get the intensive treatment and then go back home. And so it offers some opportunity for access to care. We're also a group-based program. So in our treatment program, again, it's intensive and it's group-based. And so this one solves the problem of not enough providers to provide treatment. And so what we've looked at is, again, increasing evidence that says that group therapy can be as effective as individual therapy, especially when you're using a structured program. So the nice thing about CBT is that it is manualized and that it's skills-based. And so to be able to take these skills and to teach them in a group-based setting kind of can really be helpful. And we found that it helped, it's an opportunity to maximize the trainee and supervisor time. So many of our groups are actually run by our students with our supervisors kind of looking over the group, which actually allows us to expand our bandwidth. And there has been kind of the question of confidentiality between patients and how's that going to work. And what we have found is that Sometimes it does take a little while to get kids to agree to come in. They're worried about what peers are going to think. They're worried about information getting out. We're not a process-oriented group. This is CBT. So again, it's more skills-based, and it's more kind of very specifically targeted towards goals. And so there's less personal disclosure that happens in the groups. But also, what they find is that it's actually really helpful to be in it with other kids who are going through it. Oftentimes, when you have mental illness, it can feel very lonely, like you're the only one who's suffering, and everyone else around you is somehow okay and doing what they need to do. And so to be able to be with somebody else and see other people who are going through the same thing can be very validating. And then what we also find is that kids who've been in our group, who have found progress, can be very helpful to the kids who are brand new in the group. In that they can see what progress kids with similar problems can make, and that can be very encouraging, and they encourage each other. And frankly, sometimes they actually believe each other way more than they believe adults. And so it's a beneficial kind of dynamic to have each other as accountability factors and supports. So the next piece I wanted to talk through are therapeutic approaches. And so as I mentioned, kind of the heart of our treatment for anxiety disorders is CBT with exposure and response prevention, or CBT and ERP. But what we have found in our clinic is that, again, by the time that kids present, they often they've gained additional comorbidities or additional life problems that CBT has not might not fully address. And so what we've started doing is pulling in pieces of other therapies. So we're not necessarily doing full on the other therapies, but we found other manualized therapies that have some skills that can be helpful to kind of address some additional issues that might come up for those patients. And so we talked about CBT, and what we also do is we really emphasize the exposure-based piece for the CBT. Motivational interviewing, so this one was an interesting one. So oftentimes parents will come in and they've tried the authoritarian, you just need to do this approach. They've tried the kind of, we're gonna hold the hard line and do it, and for many kids that works. And so I think it's a very appropriate first step. But for many of the kids who come to us, it doesn't work. It actually gets them more stuck. And so what we do work on is kind of integration of motivational interviewing, where we try to find where where that student is, where that patient is, and meet them where they are, but gently guide them kind of in the direction where we want them to go. I'm going to, kind of in the interest of the time, I'm not going to go into great detail of the motivational interviewing, but I will talk through a little bit of DBT, or dialectical behavioral therapy, as well as a new wave of CBT, which is acceptance and commitment therapy, or ACT. Those are kind of two of the major therapeutic approaches that we've actually been finding pretty successful in helping some of our more stuck kids get unstuck. So DBT was originally devised for borderline personality disorder and in adults, and it's been well researched for borderline personality disorder, shown to be very effective, and it's been kind of modified and used in multiple other ways, kind of in some ways kind of off from its kind of original purpose. But when we use it kind of to really address intense emotions. So when we have patients who come to us, for example, Molly, when she would get overwhelmed by her perfectionistic thoughts, she would go to her amygdala would start firing, and her frontal lobe would kind of go dead. And so she was in this place of pure emotions. And so no matter how much we tried to bring in the CBT, she was not thinking rationally. And so we really did need to think about how do we help her recognize that emotional intensity in the moment and bring it down, because otherwise there's just no engagement. We're just missing each other. And so, so when we find that somebody's really struggling with intense emotions, we'll sometimes bring in some of the DBT aspects to help target specifically that emotional intensity. And so, so again, this is very much simplifying DBT, and it's taking a component of DBT that's helpful to target a kind of a very specific presentation that we find. So this is different from what we might use, for example, DBT in our DBT clinic, where kids are actually coming in with kind of true personality disorders. But the skills the basic skills of DBT are mindfulness, distress tolerance, emotion regulation, interpersonal effectiveness, and with adolescents, walking the middle path. And so mindfulness really is about learning to be in control of your own mind instead of letting your mind control you, right? So is it you who's in charge, or are your emotions in charge? Distress tolerance is about getting through a challenging situation without making it worse. So, right, we can, when our emotions are high, we might make decisions that will actually make the situation worse. And so, distress tolerance is recognizing that and saying, okay, we're not trying to make this situation better. We're just trying to get our emotions down a little bit so that we don't make things worse. Emotion regulation is more about kind of understanding your emotions, recognizing your vulnerabilities, and effectively using those emotions to help you through your everyday experiences. Interpersonal effectiveness is about thinking about connections with people and how you're interacting with people and how you're getting your needs met with people and how you're communicating with them. Again, we're all about connection, right? And connection really matters. It doesn't feel good to have an interaction that in which we're ineffective. And so the more we can deliberately help them think through those interactions, kind of overall can help with their emotional intensity. And then walking the middle path brings in, as a child and adolescent psychiatrist, we think about families, right? And so we're not just treating the child, we need to treat the whole system. And so we bring in the parents to kind of also think through what role they play, how they interact with their child, what might work with one child, with one might not work with this specific patient. And so we use some education around that. And so DBT mindfulness, so we'd kind of talked a little, even in the yoga practice, right, kind of this how are you directing your attention and this importance of attention, right? And there is some data to show that that mindfulness does kind of help bring on that frontal lobe. It does kind of help, and again, so in this anxious brain, that can be very helpful. So instead of kind of everything going through that amygdala, I'm kind of really trying to bring on that frontal lobe in kind of thinking. And so, so in DBT, we use mindfulness from a kind of emotion mind, reasonable mind, and kind of the connection is the wise mind. So this idea of recognizing when you're in an emotion mind, recognizing when that amygdala is firing, and kind of leading you to potentially make decisions that are not going to be helpful for you, and trying to bring yourself down to wise mind, where you can take into account both kind of your emotions that are important and that do communicate to you, but also bringing in some more of that rational thinking, so that you can really kind of effectively think through what is going to be most helpful for me to do right now. And so, as I'd mentioned, distress tolerance is really about kind of crisis survival, getting through that moment. So it's really helping you, when you're in emotion mind, calm things down a little bit. And so we think about Molly, and she was somebody who really she had a very big physical response. And so when she would get emotional, when her limbic system went, she would start feeling more suicidal and want to self-injure by cutting. She really, that physical feeling, that physical pain was something that helped distract her from the emotional pain that she felt. And so, so her self-injury, as she tackled the perfectionism, started going way up. And so what we started teaching her were distress tolerance skills. Recognize when you're going to emotion mind. Recognize when those emotions are very high, and stop thinking, because your frontal lobe is not able to do what it needs to do right now, and just pick a distress tolerance skill. And again, because she felt such a physical intensity, she really found the tip skill helpful. So that's one where we look at temperature. And so ice diving is an example where she would literally kind of dump her face into a bucket of ice water just to kind of cool down her system. Or she would engage in intense exercise, anything to just separate the kind of that intensity and just lower the volume. And then once that volume was lowered and she was into kind of that more wise mind place, then she could actually think through the process of what was happening and then make a more kind of reasonable and emotional mind, the more wise mind decision. So if there was a problem that needed to be solved, she can kind of think through how she was going to solve the problem. But in her case, with the perfectionism, it was she was not ready to solve that. So really it was more about, are you going to self-injure in this moment, or are you going to do something that's more effective? And so she would choose opposite action to emotion, where instead of self-injuring, she would, or instead of just or shutting down and just getting in bed, she would actually go out, try to be with people, and put herself in a situation where she could not engage in whatever it was those emotional urges were telling her to do. So that was a very, very, very quick and superficial run-through of kind of how we integrate DBT to kind of help some of the comorbid symptoms that come up. And so ACT is a pretty new therapy that's come to our attention. It's a third wave of CBT, and it's been developed in response to this notion of not every thought can be changed. And we found this in our clinic too. Sometimes you sit there and you'll argue with those anxious thoughts, and they will just feel more rigid about those thoughts because those thoughts just feel very true. And so acceptance and commitment therapy has come to say, rather than challenging those thoughts, let's accept them. And so it's really based on this acceptance and mindfulness process, saying allow the thoughts and feelings to exist as they are. So they're separate, and then you separate from them. But don't try to change them. Let them be, and keep them in context of what your values are. And so make committed decisions based on your values rather than on what your thoughts are telling you to do. And so this applied to Molly, actually, very importantly, where she saw her perfectionistic thoughts as protective. She did not want to change them. Because if she let go of them, then she was not going to do well enough to get into college. And then if she didn't get into college, then she was going to fail at life, and what's the point? And so whenever we tried to get her to assess, okay, how important is it to make straight A's? Other people have not made straight A's and still gotten to college. She could always find some way it did not apply to her. And so we found that, again, arguing with her in that way, or asking her to lower her standards, actually caused her to feel distress, saying, oh, you don't think I'm smart enough, you don't think I'm good enough, I see I am a failure. And so we actually brought in ACT. And what I really like about things like ACT and the DBT is that I can do this in a psychopharm meeting. And so it can be a brief visit where I check in about medications, and then I say to her, okay, so how's it going with this perfectionistic thought? Okay, I'm not going to argue with it about it, but let's think about a different way to interact with this thought. So rather than having this thought as being your truth, that is driving you, let's label it as what it is, be aware of it, and then let it be. And then we clarified what her values were and how acting in response to her perfectionism was basically keeping her from achieving and moving in the direction of her values. And so it kind of looks like the monster sitting next to you, right? And so the idea is that rather than trying to change those thoughts, just let them be, but focus your attention on what's important to you. One exercise we actually do in our clinic with the kids is called Passengers on the Bus, and it's actually an experiential mindfulness where we'll have the patient actually identify what their value is. So for example, for Molly, her value is getting to college and kind of getting a good education. But and then we'll identify all kinds of the perfectionistic thoughts that come up. And all the students, all the other group members will then take kind of those thoughts and they'll start whispering those in her ear or start yelling those in her ear. And the idea is that as you're moving towards your values, these thoughts can keep coming and they can keep talking to you, but focus your attention on that value, where you're trying to move. And so rather than making a decision based on what those thoughts are telling you, you're not good enough, you're a failure, if you try, you're never going to succeed. Rather than listening to those, pay attention to what's in front of you, pay attention to that value, and drive towards that, and make decisions that are based on that. And so again, not trying to change the thought, not trying to get her to think that not getting straight A's is the goal. The goal, though, is what can I do in this moment? What behavior can I choose that's in line with my goal? So my behavior right now is to actually get out my book and do my homework, because that's in line with my value, no matter what perfectionism tells me about how I'm not going to be able to make the A+ on it that I want to make. So holistic practice. So this one is a new one for us, so not as innovative here in India, But definitely innovative for us. And so we just heard a beautiful presentation on yoga, right? And this is something that we want to integrate into our clinic, and we've been talking about it quite a bit. And so that's actually a picture of my daughter with two of her friends doing some yoga in our house. And the evidence is still emerging, and yet it's very, very compelling for how helpful it can be. And I wanted to raise my hand and ask the question about also anxiety disorders and kind of how much it impacts that, because anxiety is a very sympathetic body experience, right? And so by eliciting that parasympathetic response, you can see how that it can be very helpful. So, and interestingly enough, yoga is actually getting into the schools way faster than it's getting into the clinics. And so a lot of our local schools have started doing yoga practices with the children. And so this particular study was done in a school setting with third graders who were diagnosed with anxiety symptoms. And so they were over 8 weeks given 10 sessions of yoga, vinyasa and ashtanga, and some mindfulness 40 minutes before school. And they found really positive results around psychosocial and emotional quality of life. What they also found is that the teachers, when they learned about this, started incorporating it into their days as well. And so this is something that we're very far behind in the US, and it's starting to gain a lot of traction, just given how impactful it really can be. And then from the holistic perspective, again, this is where we have a lot to learn from the practices done here. But we talk through the basics of kind of nutrition and sleep and movement. There's a lot of attention on the gut-brain connection with anxiety disorders and kind of the impact they have on each other. Positive psychology has been kind of coming into and thinking into the practice, as well as Ayurveda and kind of spirituality. But all of these things very different from kind of the Western thinking that we traditionally have, but things that we're much more increasingly embracing and seeing as a necessary part of treatment. And then technology. And so again, one of the big issues for us is that we talked about, even though we are very well resourced, we still are not able to meet the demands. And so we're starting to think about what are some creative ways we can kind of expand our reach. And so we've integrated the use of telehealth into our clinic. We're still in the early stages, but in the last kind of even 3 years, it's really exploded in the United States as digital health has become kind of more prevalent. And so currently we're engaging in provider-to-provider school consultation work through using telehealth. So when a school is too far for us to be able to actually go in person, we will kind of engage with them through that. But what's also been a lot of fun to use is in our clinic. And so we actually, for example, just had a how old is he? I think he's a 14-year-old, no, younger than that, maybe about a 12-year-old boy who came into our clinic with severe social anxiety. So he is terrified to meet new people. And so he came in once and then felt, wait, I don't think I can come back in again. And so what we've started doing is engaging him through telehealth. And so his parents will set up the screen, and he kind of sits on the floor, so he doesn't get on the screen yet. But the parents will engage with this, and he gets to hear what we have to say. And so it's kind of slowly getting him used to this, because prior to this, he's not been able to get any kind of treatment because he cannot get his foot in the door. And so it's just an opportunity for engagement. And then we've also been using it for skills coaching. Again, we've had lots of kids who come to us who just have a really hard time getting out of bed in the morning because their anxiety is so severe. And so the kind of the ability to be able to kind of in real time engage with them. And this is another place where having where we've used, where our students have really gotten to do this, where kind of skills coaching in a very specific CBT model allows for them to engage, and again, expands our scope and bandwidth. So I talked about attention bias and how we're starting to understand better kind of the neurobiology of attention and how that impacts anxiety. And so very much still a work in progress is attention bias modification treatment. And so the idea for attention bias testing is that you'll have a computer screen or a phone screen, and then you'll have a kind of fearful face or kind of a not so happy face, and then a neutral face. And then it's hard to, no, you can kind of see it, but then there'll be a kind of the next screen will be a little signal that's in place of either that scary face or the neutral face. And they'll measure kind of how long it takes somebody to click between when they see that that dot. So that's a dot probe test. And so the idea of attention bias modification is that they'll always have that dot replace the neutral face in hopes that you're retraining that brain to focus on the neutral. Now that and so this is still very much a work in progress, but the idea is that what you're doing in that process is strengthening that connection between the ventrolateral prefrontal cortex and the amygdala. And so that after training, that connection is a lot stronger, and that the attention bias is weaker. And so that somebody who's feeling anxious is less likely to subconsciously kind of direct their attention to the threat. We tried the attention bias testing in our clinic. Right now, the unfortunate part is that it's really boring. And so, so we'd have the kids doing it on the computer, and unless we were right there on top of them, they would just kind of start playing around. And so it's still a work in progress, but but again, it's one of those very promising treatments in that it's not something that has to be delivered by a clinician. And as kids and kids love technology, and so as they're comfortable with this, and so this is another way to kind of address that issue. So it's something to kind of that we're very excited about, and will hopefully continue to progress on. There was a recent kind of review of the studies, and there are 10 studies kind of looking specifically at attention bias modification in children and in adolescents, and they found 3 of them were randomized control trials, and they saw it as promising as a possible treatment. Again, there's a lot of kind of heterogeneity in how the studies are conducted, as still trying to figure out what dose to use, how specifics to do the programming. I couldn't talk about technology and not talk about apps. The hard part about apps is that they come and go and there's no regulation. And so what we've learned mostly about apps from our own patients, where they come in and they'll say, hey, I've been using this app and it's been very helpful. And so while we don't see this as kind of a replacement for therapy, it can often be helpful, again, in that homework piece, that accountability between sessions with therapy, where we're finding it's really important that they kind of continue thinking about what they're learning in their therapy. And then we are not doing computerized or internet-based CBT in our clinic, but again, it's something that I felt important to mention, only because there's growing evidence for kind of effectiveness, and the question is, can this be delivered on its own? Is this something to be delivered kind of in conjugation with in-person? So can it expand somebody's bandwidth by providing some of the basics of treatment, and then you go to the treater for kind of a more kind of in-depth treatment? And what we're really excited about is that we're starting an exposure therapy pilot via virtual reality. And so the idea here is that the virtual reality has really, just even in the last year, has really progressed quite a bit, such that virtual worlds look pretty real. And the equipment is getting more and more affordable. And so, and there have been some studies kind of done in adults, primarily looking at exposure therapy for anxiety disorders. And so in our clinic, what we are piloting is having a virtual world of school, and having students come into this virtual world and coaching them through some of the fearful situations in a virtual way, and with the hope that might help them feel more willing to then engage in the real thing, and feel more prepared to engage once they're in it. And then finally, wanted to talk through collaboration, because as a child psychiatrist, the patient is not just the person in front of you. The patient is actually the whole system. And it's something that we remember every single day, but it's also what makes our job the hardest, because it's very labor intensive or resource intensive. It's very difficult to make all the phone calls that we want to make sure everybody's on the same page. And so what we've been really trying to think about is how do we collaborate in a more systems way. And so wanted to just very quickly talk through some of the work we're doing in schools. And so the kind of model that we're using and that schools are moving towards now is this kind of 3-tier model of addressing kind of mental health or social emotional needs of students. So universal interventions are interventions that are good for everybody to have, that no matter who you are, it's good for you to learn this. Tier 2 interventions are interventions for if you're at risk for developing anxiety or depression or post-traumatic stress disorder, we might kind of give you a couple of these things before you get to tier 3 level, which is you have a diagnosed disability and things are really rough and you need quite a bit of extra services. And there's a meta-analysis of 213 universal programs that found significant improvements in a lot of different measures. And so, there is quite a bit of evidence that shows that tier 1 interventions can really make a difference. And so we've been seeing a huge trend toward implementing universal interventions in the US schools. And again, there are great interventions out there. The issue has been actual implementation. This is a very busy slide. I apologize for it, but I found it really, I mean, it's helpful to see. So it lists out kind of some of the universal interventions that are out there, and they're done both in kind of the high-income developed countries as well as lower-income developing countries, kind of saying that this is not something that's isolated to kind of well-resourced centers. And again, many of these are based in CBT. And so there's plenty that's out there for the universal interventions. What we have found is that what is still lacking are those interventions that are more tier 2 or tier 3 for these kids who actually have kind of psychiatric problems. And so that's what we've started doing in our engagement with schools. And so we're working on just kind of addressing stigma, addressing education, kind of teaching people in the schools, how do you identify this? I thought when we started our anxiety program that capturing anxiety in adolescence meant we were going to capture things early. What we're finding is that even by the time they get to adolescence, they've already had quite a bit of loss. And so now I'm thinking we need to catch this even earlier and kind of when it's first coming. And schools are in a great position to recognize that. And we've been working with them to kind of develop a common language for them to approach it. And so we actually created a toolkit that includes kind of, again, concrete skills and strategies from CBT, DBT, from the motivational interviewing, and from ACT that they can implement. And again, it's a language, so it's not necessarily something that needs to be separate, but it's something that you integrate in. And so it's a new way of engaging students. So, summary, adolescence is a prime time of opportunity and vulnerability. So again, great time for us to intervene to really help shape a child's life. The traditional treatments are effective, but they have their own limitations, and so we do need to get creative in how we approach their treatment. So, thank you.
So, thank you so much, Mona, for that very holistic talk. She started off with etiology, the developing brain. We went on to best practices and, of course, non-responders, which is an area of interest for all of us. And then the non-pharmacological treatments, where DBT not in personalities, obviously at this age, and the new ACT, acceptance and commitment therapy, and the innovations, which were very interesting. I loved the context of yoga and holistic help in schools, and she moved on to actually going out into the community and empowering teachers with life skills training, which is, I think some of us have dabbled with it, those who have worked with children and adolescents. So thank you very much. And now if there are questions, why don't you join us? Yeah. Come. So, yes, Ashutosh. Please introduce yourself to the house and...
Yeah, hi, I'm Ashutosh, and I have a question. Pardon the ignorance, but when you said in your first slide, maturation of the brain, what does that mean actually? Is it myelinization of the neural tracts? Is it synaptic connections and pruning? Or is it something else?
Can you talk into the mic? Because I think people behind aren't hearing you.
Sorry for this. I'll repeat the question. When you said about maturation of the brain, what does it mean? Is it myelinization? Or is it synaptic connections and pruning? Or is it something else?
So is this on?
Yes.
Yeah. So my understanding is that it's all of the above, but really it is about the synaptic connections and the myelination. It's actually in the adolescent brain. It's a very, very important time for myelination. So it is kind of developing those connections. The dendrites are actually are creating lots and lots of branches, and again, with synapses that are being used more frequently. And so rudimentary clinicians' understanding of brain development, and as much as we can understand. There's the big ABCD project currently underway where they're neuroimaging kind of hundreds of adolescent brains over time to understand better what's happening.
And just drawing on that, on your slide on holistic approach and diet, I mean, there's a large role today of junk foods, diets, neuroinflammation, inflammation in general, obesity, overweight, metabolic disorders. So what about this understanding of balanced diet of omega-3, omega-6 fatty acids? I mean, how much are you actually implementing in your practice?
Yeah, no, it's a great question, and and the United States is particularly bad for this. Our children are very obese. We're very and it's only growing. I have another talk where I show the slides, and it's staggering how much obesity has been increasing, and it's a very junk food related culture, and so. And so I absolutely do talk through omega-3s, but even before that, we talk through kind of how do you integrate some healthy components to your eating, recognizing that there is this gut-brain connection, and we know that the junk foods do not create a great microbiome. And however that microbiome is interacting with your brain and vice versa, it's not productive. I mean, there's some animal models that actually show pretty significant changes in depression and anxiety when you transfer kind of microbiome from one rat to another. And so we'll talk through that component, and then we do talk through omega-3s. I mean, I think that the evidence is moderate, right, in terms of how much it can impact, but the risk is low, and so we talk through the risk-benefit. It's like there's low risk for increasing the omega-3s in your diet, and ideally you do that naturally through actually eating fatty fish or kind of the nuts or the natural supply. But if you can't, then supplements are available, and so we definitely talk through that. I'll say that it's one that Americans have a hard time shifting. Yeah.
Yes. Some more questions out here? Yes.
I'm Dr. Samin Mansoori. My question is that given today's time where smartphones and social media problems have increased, especially in children, be it cyberbullying or selfie manias, in your clinical practice, what are your do's and don'ts for parents to stop these events?
To stop the use of social media or?
Adverse effects which are coming, be it cyberbullying or the selfie manias. So there's a huge market for parental controls on social media, and I'm mixed about that because in some ways we need to teach the kids how to effectively use the media that's out there, because at some point they're going to be out on their own and they need to learn how to do it. I think in some ways we're very behind. The social media and technology is progressing so rapidly. We're slowly catching up, but it's well beyond kind of, there are no rules for so much of it. And so we do talk to the parents about it, and at the same time, it's very hard to stay on top of kind of what social media the children are using, because they're rapidly, so it used to be Facebook. Very few kids actually use Facebook anymore because all of their parents got onto it. And so then they'll move to Instagram or Kickstart or whatever. And so again, our big thing is actually educating the children and saying, can you pay attention to how this impacts your mood, how you're engaging with it, what are the benefits of it, but what are the downsides of it, and trying to really educate them in terms of the decisions that they're making.
So just to add to that, I think social media is something like sex education. Parents don't want to talk to their children about it, but they expect their children to talk to them when there's an adverse effect. So unless you're going to talk to them about sex, they're not going to tell you about sexual abuse, right? Similarly, you have to be equipped with the knowledge of media in general in order to help your child combat these kind of things. Yeah, we have a question over there.
Hello, ma'am. My name is Dr. Prashant Chaudhary. I'm from McLean Hospital. I have this one question that there is this adaptive fight or flight response in animal kingdom where we respond to the stressful situations by either fighting or by running away from it. Now, in modern times, because of society, we can't always fight or flight. Or there are, and previously that response used to be for physical and real threats. Now it can also be for some imagined threats. So what I want to ask is that, do you think, first question is, do you think anxiety as a phenomenon or feeling is born out of suppression of fight and flight response? And second question is the distress tolerance in DBT actually causing the suppression of anxiety, like suppression of these responses? Thank you.
Great questions. So absolutely. So it is one of those, right, when we think back to kind of primitive time where that fight, flight was incredibly important. You have a lion chasing you as a caveman, you need to get out. You need to be anxious. It's important, and you don't need to think. You need to act. But fast forward to today, there's not quite all that danger presenting, and yet our body is acting as if that is. So our bodies are built for intermittent stress. That's fine. We have a system in place for that. But what's happening now with anxiety is it's chronic stress, and that chronic stress really wears on the system. It wears on kind of the heart. It wears on the GI system, the immune system. It just kind of from a physical perspective as well as an emotional perspective. We're not built to be in that chronic anxious position. But absolutely, I mean, I think so it's an adaptive system that now environmental factors have come in and kind of have kind of messed up our response to that adaptive system. And with distress tolerance, so I'm a big proponent of we do not use distress tolerance all the time. The time to use distress tolerance is when you notice that you are so high up. So we kind of think about anxiety as a spectrum from 0 to 10. When you're at 9 or 10 and you cannot think because you're so overwhelmed that anything that you do is probably going to make things worse, that's when to use the distress tolerance. But ideally get yourself to that zone of 6 or 7 where you can more adaptively manage whatever is happening. I think the problem is when we are up in that high zone and we make decisions that will sometimes make decisions that make things worse, and then we think, oh, see, this anxiety was really bad, and we don't get to learn. And so again, it's not a skill that I would say use consistently, and I usually say use it with another skill, because I agree, I mean, we don't want avoidance. Right, we really want to address anxiety by confronting or approaching.
Yes, sir.
I'm Dr. Vasudev Paralikar, and I need to ask you what happens to the untreated anxiety, because there is a large gap, treatment gap. So what are the adult life consequences of untreated anxiety? How it goes into different directions, personality disorders, depression, psychosis?
Yeah, no, absolutely. I mean, and so I went to a talk by Ron Kessler, who's a Harvard epidemiologist, and he talked about exactly this. He said, and he coined anxiety as a gateway disorder, similar to how marijuana has been coined as a gateway drug, to where you start with it and then it will lead to other things. And kind of similar, this idea that anxiety that's left untreated is going to cause secondary problems to arise. So we most frequently in the adolescent age see it as depression, right? You're anxious, you start avoiding things that leads, and you start missing out on things that are important to you, and that brings on a depression. Or kind of you don't learn how to cope appropriately or effectively with things, so that kind of leads to avoidance of other things or substance abuse. And we've also found that kind of later in life, it leads to kind of trouble with marriage, trouble actually graduating from college, and kind of just more life consequences. Yes.
Hi ma'am, I'm Dr. Sonia. While yes, rapid, intensive and brief therapies do work very well in anxiety, I would like to ask you, how well do the kids really follow through on whatever they've been taught and trained for eventually? Because we've technically not given enough time in rapid therapies for the brain and the client to get used to what we are trying to teach. Mm-hmm. So how effective is it post once the crisis anxiety phase is gone and the child is relieved?
Great question. And that is exactly why we're engaging schools. Because what we're finding is that kids are coming to us for this intensive treatment, and we're seeing amazing gains in kids who had been failing treatment otherwise. So that was encouraging, but what we were finding is that then they would go back to their school environment, back to what they were doing before, and over time they were forgetting what they learned. And so a big component of what we've been thinking about is how do you continue to remember? The kids who've done the best are the ones who keep their relapse prevention book, and they will keep referring back to what worked for them. So some kids can do that on their own. Some need coaching and help. And so this is where our solution has been engaging schools and saying, okay, school, let's identify a counselor, let's identify a teacher, somebody who can kind of continue to check in with you and help you remember what is helpful for you.
So train the trainer kind of approach would really help post.
We've been finding that has been one effective way to do it, with recognizing resources, right? Because similarly, we've saturated all of the CBT therapists in our community, so we actually don't have CBT therapists to refer to either, which is, again, very strange to think when we think about how resourced we are. And so we've turned to the schools for it.
Okay, Fabian? Yeah.
I'm Dr. Fabian Almeida. I work closely with school mental health. The practice commonly here by principals are to give out suspension orders 5 days or more for children who are indisciplined. Now, since we often play the devil's advocate, what's your take on this, and what can we do better for this practice?
So it's interesting because in the States we have a clause called manifest determination. And so if somebody is determined to have a disability and they engage in some kind of behavior and it's part of their disability, then they cannot be disciplined for it by suspension. But instead, they have to have their disability addressed. And I think that has been really important. And I mean, and because, again, by suspending them, we're not teaching them the skills deficit. These kids have a skills deficit. And so when they engage in an act that is problematic, it's important for us to say, okay, what is it that you need in order to not do this again, and how are we going to teach you what it is that you need? And part of our point has been educating the teachers in school about that, saying this is not a kid who's trying to mess up their life and trying to get suspended. This is a kid who actually has a skills deficit, needs some additional help figuring out how to do this more effectively. So what is it that we can do? Let's talk through some things that we can do to help this child.
So a lot of liaisoning with the schools required. Dinesh, you have a question? Yeah, you can.
Madam, Madam, do you treat the children with anxiety disorders in different patterns? For example, stranger anxiety, separation anxiety, phobic anxiety, performance anxiety, Eid anxiety, whatever, or free-floating anxiety, panic attacks, or you are taking all the anxiety affected children in only in one pattern?
All of them. And most of the time they come with several of them. So it's rare that we have a child come in with just one kind of subcategory of anxiety. Frequently we'll have somebody come in who has social anxiety plus generalized anxiety plus panic with agoraphobia, and they've become depressed. But we treat the gamut, including all of that you mentioned, and then there's selective mutism that we've also seen, and then there's some other anxiety-related issues.
Do you apply deconditioning methods or anything for these anxiety disorders?
So deconditioning, kind of similar to exposure therapy. Can you describe for me what the approach of deconditioning would be?
Desensitization.
Yes, right. So that's what exposure and response prevention is exactly. So the idea that there's a stimulus that's fearful, and you're going to gradually engage in that in order to show that you can handle it and that you can manage the anxiety that comes up with it.
Dr. Pramod Thakre.
Ma'am, I'm Dr. Tembe. I'm from Karad. I practice in a rural setup. Kind of now what we are facing is people using weed, the children most of the times, and that is one thing that they are saying, that it helps them reduce their depression, their anxiety, especially with social phobias, the peer pressures. All these are reduced by use of weed.
Yeah.
So how do you suggest that we should face these?
Oh, this is an interesting one. So I worked on it prior to moving to the outpatient clinic. I worked on a residential adolescent substance abuse unit, so I met a lot of kids who were using a lot of drugs. And one thing that I did notice is that there was something about some of the kids who came that they did seem better with the substance, with the weed, but they couldn't use it in a controlled way that was helpful. So inevitably, it went to disorder because it was not controllable. We have a researcher at McLean, Stacy Gruber, and so she's doing quite a bit of really fascinating work, specifically on marijuana and psychiatric illness. And she has actually separated the different components out, and so she's separated the cannabinoid out and has found some really interesting preliminary evidence that it actually can be helpful for disorders such as anxiety and depression, in that it helps cognition, it helps lower symptoms. It's early stage, and it's not what they're getting in rural India, right? I mean, the problem is that what they're picking up, I mean, even in the United States, the weed today is 20 times more potent than the weed back in the 70s, right? So it's a different beast. And so what they're using is going to be more addictive, it's going to be more problematic, it's going to mess with receptor systems that should not be messed with when you're developing. And so, so what I do is I engage with them in kind of that psychoeducation of, okay, so what evidence we do have is when you smoke weed, that's available, kind of like on the street, we know that you're going to lose IQ points because you as a teenager, your brain is more susceptible. If you start as an adult, it's not as big of a deal. But starting as a teenager, you're hurting your brain. And so we do a lot of education around it's a vulnerable brain. So I'm not telling you never to smoke. I'm just telling you to delay it. The more you delay it, the more that you're saving kind of your brain and its development. And I get it. You're feeling anxious. Totally makes sense. And so how do we figure out another way? And oftentimes what we have to say is nothing I'm going to give you is going to make you feel as good as the weed makes you feel. And so it is. So I recognize I'm asking you to do something very hard when you choose to address your anxiety in a different way. Yeah. Oh, yeah.
In fact, what we are getting here in the rural setup right now, the weed, is quite the way what you are saying, that what you used to get in the US in the 70s. But the children are coming to me, at least, that where can I get good weed?
What do you tell them?
And I hope you're not answering that, honestly.
No, but I mean, again, I think it's very important for them to pay attention to the big picture, right? I mean, because oftentimes what we see is that along with it might help with the anxiety, but along with it comes an amotivation syndrome, right? Where it impacts memory, so they might get some benefit in something, but then they get the downside in other areas that are also important. And so really being able to take a step back and say, okay, let's look at this in the big picture and how this impacts what you want for yourself, and engaging in that way.
Yeah, so nowadays they come and ask, because adolescents know everything on the net, that, you know, how much do you think my brain is actually going to get screwed up? And I said, well, pretty much a lot. That's what we can tell you. We don't know how much it's really going to help. So it's your call to take whether you want to be responsible for screwing up your brain. And that really works with them, because the loss of control is something that they don't like to address. Yeah, we have a question there.
Yeah. Myself, Dr. Jyotik Bachej from Ahmedabad. My question is related with the question which Dr. Shamim asked. Here where I practice, the major challenge is parenting, because parents are really not willing, or they are just having a challenge that my child is at a problem and why you are doing a parenting session with us. So my question is that, do you have some certain modules for parenting session, and do you continue parallel with this DBT module? One thing is that. And second, regarding the telehealth, there are children who are coming to me as well as teens with the gaming addiction. And what is their complaints if we adopt this model, that do they increase that gaming addiction with this telehealth?
Okay, so I'll try to remember both questions with my slightly jet-lagged brain. So if I forget, remind me. So the first question was about parenting and modules. And so in our anxiety program, we actually do require that parents are also part of the treatment. Again, with this idea of systems-based care, and if we send them back to a system with no changes, then it's going to be very hard to maintain any gains they make in treatment. And what we'll often talk with parents about when they say, I'm not the problem, it's my child. Look, I have another child who's completely fine. What we'll say to that parent is that that every child is different, and every child comes with a different vulnerability. And what worked for this child might not work for this child because of the vulnerability this child brings to the table. And so what we need to help you with is thinking through strategies for how to parent this child. So again, taking away the defensiveness of there's no right or wrong way, but there is an effective way for this child who is there in distress. And again, it's a lot of psychoeducation around anxiety and kind of helping them understand that sometimes when they're avoiding, it's not to be lazy or to be manipulative or to just, it's because they're really feeling overwhelmed. And so a lot of it's empathy building. And then the second question was increasing addictiveness. So the telehealth sessions are just not that interesting. And so, so if anything, I think what we run into is sometimes they will just shut the screen when they're kind of sick of looking at us. And so we actually do require that a parent is present because we're asking them to do things they don't want to do. And so if anything, it's almost aversive for them at times. But it is something that parents bring up. And as we're thinking about the use of apps in treatment and the use of kind of even the internet-based CBT, as we're getting them more engaged, there is that risk of kind of how much interaction are they having with the social media or with the computer, and it is something that we absolutely need to keep in mind.
Yeah, we have a question.
Hello, myself Dr. Bharat Sarode from Pune. In your one of the slide you have shown about OCD and CBT. So it has shown a good response only for CBT and along with medicine. But what is the relapse rate of more severe variety of the OCDs along with the CBT? Whether they continue the CBT and when they stop CBT, whether the relapse of OCD symptoms come? So and another thing, how long you continue this CBT for OCDs, and are there how much relapse rate is there with OCD symptoms?
For how long do you continue the CBT? And
CBT for OCDs.
Yeah,
and only.
For OCD?
And so as far as I know, they have not done. So I will have to get back to you on that one because they have done some follow-up trials for POTS, but I don't remember that off the top of my head. They did look at for the camels for the generalized anxiety. They did a 6-year follow-up and found that generally speaking, the kids who responded well were the ones who did better. I mean, I think that the longitudinal evidence is really hard to get, especially kind of with the clinical population. So, so that's one that I don't know how great the follow-up is in terms of how much relapse there is once you do respond. And the studies right now kind of look at more truncated treatment. So the POT study was a 12-week CBT treatment and kind of showed the response rate at the end of the 12 weeks.
Which are the medicines which you opt for the childhood OCDs?
So I actually anticipated a medication question, so I had written it. So first line are the SSRIs, and right now sertraline is the one that has the most evidence to support it, and so sertraline is kind of oftentimes our first go-to, just because it's easier to do an informed consent. But in truth, I think that generally speaking, kind of best clinical practice as far as what we practice is that whichever SSRI you feel most comfortable with, or if there's a relative who responded well to an SSRI, then we'll start with that medication first, because sometimes there's also that placebo effect of, oh, this person responded well to that, maybe this is going to be helpful for me. So if somebody has a positive affiliation with a medication, then I might choose that SSRI first.
I think the questions have to be directed here. Not there.
So if you have questions, we have time, we can ask. Yeah, Rukshita, you have a question there.
Hi, I'm Rukshita. I practice in Mumbai. So I primarily have an urban practice, but I have a practice that's in private practice as well as community. I work more with adolescents and parents of young children. So 2-3 questions really. Especially for a child who's older, especially after high school and things, when there is a certain amount of anxiety and also occasionally OCD. So I have started really encouraging if the idea comes from them as well about taking a gap year, which again is not a very, very popular scenario in India. So I really struggle with it because I'm the enemy as far as the parents are concerned. And what would you say about that? Second, for the younger children, I'm seeing a lot of school refusal in private schools and public schools and all of that. And a lot of population, especially in a metro like Bombay, there are 2-income households, so both parents are at work. So if there is child refusal, it's really, really difficult. And we have no kind of concept or we have no proper steps for homeschooling. So that again is not an option really. So how much would you what would the strategies be? How much would you enforce or encourage, or the child has to go to school, that kind of a thing? And the third thing is, how early on is it okay for you personally to start an SSRI in a child with anxiety, especially with school refusal?
Okay, so again, I'll try to keep all the questions in my mind. So the first question is about gap year. And so we run into this challenge as well, where again, a lot of these kids who come to us are incredibly bright and very much college bound. And so for us to say, perhaps you might want to take a year is just completely out of the question for everyone involved. And what we're also finding is that as more and more kids with disabilities, with anxiety, depression, they're getting support they need. So they're getting to college, and then they get to college and they're falling apart. And so what we talk to them about, parents about, is what we want is for them when they get to school to be able to successfully manage school. And so we talk through kind of the core competencies. Okay, what is it going to be required of you in order to be able to function independently in this setting, and how close to that do you feel you are? And so it's really kind of very concretely trying to think through the readiness factors. We actually have a college mental health center where they've kind of created a college checklist and then sometimes we'll go through it and say, okay, so you've got kind of 2 out of 10 that you're feeling ready to do. You can try it out, but chances are it's not going to go so well. So perhaps taking a year, and let's think about what you will do in this gap year to really prepare yourself so it's a useful year. It's not just kind of a year where parents might think, oh, they're just going to waste away. And so it is a really hard one to swallow, and I imagine especially here, it's becoming more common in the US, so I think we're having an easier time now, but still, especially with the very high functioning families, it gets tough. The second question was about school refusal and dual income families. And so the school refusal piece, I mean, I've been working in schools for 15 years. It seems like it's really dramatically increased just in even the past 5 years. And so it's a new condition in some ways. And so it's still one that we're trying to figure out, to be completely honest. I don't know that and I think it's actually pretty heterogeneous in that kids don't go to school for many different reasons. And so when it's anxiety related, what we talk with the parents about is there's something that they're avoiding at school. And so what is it that we need to shift or accommodate or modify at school in order to make school more doable? But then there's something reinforcing about being at home. And so what is it that we need to change about the home environment so that it's not as reinforcing? So we have them turn off all internet so they can't get on the Wi-Fi, or no media, no TV, no. And so we make it as boring as possible. So at some point they're not going to want to stay home. In home tutoring, we're very mixed about as well, because the longer they stay out of school, we find the harder it is to get back. And so we talk about, even if it's just go to school and sit in the kind of a random room all day and do nothing, we'd rather that you're actually getting through the process of getting to school than doing the work at home, because the longer they spend kind of doing that, they develop that comfort level, and that avoidance just keeps increasing.
Sorry, can I just add that? Because again, one of my concerns is the developmental trauma. It's just like, we've had so much of research on when younger children were forced to eat. Now you have to eat this and you finish, and they develop an unhealthy relationship with food, and that may lead to a whole lot of eating disorders. So now when we are dealing more with the school refusal as well, and if we are trying to enforce, I'm worried how much of that would be traumatic.
Yeah, and that's where, again, it's working together, right? And that's where the motivational interviewing does come in, where it can't be authoritarian, because then if they are white-knuckling it, then their stress response is so great, they're not learning anything. And so as much as you can kind of gauge where they're able to go and help their school environment be as, I mean, again, slightly uncomfortable, but not to the point where it's overwhelming. It might increase their willingness to actually engage, because most of them do want to be at school. I mean, they want to do what they're supposed to do. It's just they don't want to feel the way they feel when they're there. And so it's figuring out how to give them that kind of gradual, step-by-step way of getting back. But again, it's still a work in progress in figuring it out.
Yeah, and the third question was how early can you start an SSRI?
Yes, thank you. So we tend to start SSRIs pretty early. So for me, it's less about age and it's more about level of impairment. And I always talk to parents about kind of the risks and benefits of medicating and the risks and benefits of not medicating. And once we've tried, and so with the younger kids, we'll try therapy first. But for many of the kids, their biology is so great that they can't access therapy. And so we need to use the medication to even dial it down a little so they can actually engage in the therapy. So I don't look at medications as this is what's going to fix your child, but we look at it as this is what might help lower the intensity of the symptoms enough so that they can actually engage in the world and kind of get back on. Because the longer they stay disengaged, the longer they're in their symptoms, the more it gets written into their kind of inherent coding. And so our program starts at age 7, and we get many 7-year-olds who have already been on multiple medication trials.
Okay, so I think that's been a very good round of questions and answers, and we're perfectly in time. And thank you so much, Mona, for that fantastic session. I hand over.
Thank you.